right, welcome to the Alfi podcast. This is episode 5. I have a very special guest, friend, colleague, and orthodontist, Dr. Ryan Cody. You want to stay tuned to this one. This is a very special episode. We're going to get into premolar extractions, expansion, MARPEs, SARPEs, dome, segmental surgery, pediatric ortho, Invisalign versus braces. We'll talk about retainers and talk about jaw surgery, of course. You're going to want to stay tuned. Also, if you're like what you hear, make sure to subscribe, like, and share. Dr. Cody, I'm going to call you Ryan, if that's okay, in this podcast. He's a craniofacial orthodontist. So he did dental school at University of North Carolina, which actually has a very reputable ortho program.
Go Heels.
Themselves and history. And then you did your ortho residency at UT Houston. And then after all that schooling and training, he spent an extra year as a craniofacial orthodontic fellow at the largest children's hospital in the country, Texas Children's Hospital. And now he is a staff orthodontist at Texas Children's, a craniofacial orthodontist. On top of all that, he speaks Spanish and Portuguese fluently, obviously English. He's a pro baseball player. He's a jazz pianist and the most eligible bachelor in Houston, maybe in the U.S. So make sure, share this interview. All right, let's get into it. Let's get into the weeds. Let's start with premolar extractions.
Yeah. Premolar extractions were a big trend in the 1970s into the 1980s. People estimate that people that underwent braces had 4 premolars extracted.
People that went to an orthodontic office in the 70s and 80s ended up with their premolars removed.
Yeah, which gave it the term 4 on the floor, because it was just anytime there was crowding in the arch, the way that orthodontists were trained to straighten the teeth was to make a lot of space.
Right.
And then crank the space closed.
Yeah, that's an amazing stat. I knew it was high, but I didn't realize it was that prevalent. But of course, I see patients now in their 30s, 40s, and 50s. So this generation that you're talking about.
Yeah.
And obviously there's a selection bias here because they're coming with airway problems. Mm-hmm. But most of them have had their premolars removed.
Yes. We see it a lot in adult orthodontics where they got their premolars removed when they were kids, mm-hmm. and now their arches are collapsed inwards towards their tongue with no space for the tongue to move or function or breathe. Many of these patients have sleep apnea and are on CPAPs, very narrow smiles, mm-hmm. and just don't really know what to do.
Right.
Because back then, braces were like bands around all the teeth. You know, it was nicknamed train tracks for a reason. Right. Metal mouth, whatever. And now they're learning that there's other options besides braces to fix their problem.
Yeah. And thankfully, it's evolved a lot. We're learning so much. Mm-hmm. And I think it's interesting because I think there's a misconception that removing premolars, is the root of all evil in the sense that causes airway issues. I think that that's not true. I think that, the way I like to think about it is that the reason that they're prescribed premolar removal in the past was because the jaws were too small for the teeth. There was an arch issue, and it's actually the jaws being small that is the inherent problem for the airway. So I don't think that removing the premolars was the cause of what we're seeing as these sleep apnea patients. But I think that missing the notion that the jaws were large enough for appropriate amount of teeth can correlate with not being large enough for the airway. And that in itself is that the patients already were predisposed to airway problems.
Yes, definitely. We've seen, as you've mentioned on previous podcasts, jaws getting smaller over time, right, evolutionarily. And the way orthodontists in that era treated that discrepancy between tooth size and jaw size was by removing teeth. Right. When in reality, we've learned that with slow expansion, whether with braces or palatal expanders, we can actually influence the size of the jaws to accommodate all those teeth.
Right. So the idea is that when we recognize that the teeth are crowded, which is probably almost every patient that walks into an orthodontist office, right? We should be thinking the jaws need more space, and instead of thinking about removing, let's expand, right? I think that's where we're headed now, appropriately so.
Absolutely. It's almost been a pendulum where premolar extractions were at one drastic end of the pendulum, and we as orthodontists got so put off by that or scared by that the pendulum is now shifting in the other direction, where orthodontists are a lot more mindful of airway right now in this day and age, which is a good thing.
That's a great thing.
Fortunately, we're thinking about expansion before extraction, and we have several mechanisms to expand now that we didn't have before.
Right, and we'll get into that.
Yeah.
Now, so for premolars, sometimes we'll prescribe it still, but knowing that we're going to expand the jaws.
Yes.
We're going to bring the jaws forward. I don't ever think about recommending premolar extractions without a surgical plan or without an expansion plan. I think that either, at least the way I think about it, either we should be making room for those teeth, or if we can't, we should make the teeth straight and then recognize the jaws are small and bring them forward.
Definitely.
Make them larger.
Definitely. In the past, camouflage, orthodontic camouflage was a big way to fix the bite, but it wasn't the right way to address the skeleton below it.
Right.
For instance, if a patient had an underbite, a lot of times we as orthodontists could take out 2 lower premolars and pull those lower teeth back, but that's not addressing the fact that the upper jaw was too small.
Right.
And conversely, if the patient had a big overbite, they could take out 2 upper premolars and pull the top teeth back to fix the bite.
Right.
But that's not addressing the fact that the lower jaw was too small, and maybe needed to be moved forward. So that's what orthodontic camouflage was in the past.
Yeah.
Now, like what you're saying, if you have an underbite and the top teeth are very flared,
right.
One way of addressing that with orthognathic surgery is taking out 2 upper premolars, pulling the top teeth back to what's called decompensate the teeth, and then moving the top jaw forward to fix the bite and provide the best facial aesthetics.
Right. And in that sense, we're recognizing that the jaws are too small, and we're addressing that by advancing the jaws.
Exactly. And that's why orthodontic and oral surgery communication is so important. You have to tag team all these cases and be on the same page before getting started.
Yeah, 100% agree. What's interesting to me is that there seems to be so much controversy on this subject within the orthodontic community. And I feel like maybe a resistance to even discuss the premolar extractions. I wonder, what is your take on that about the controversy? Where does it get sticky to talk about it? Why are a lot of orthodontists afraid to have this discussion or even bring the premolar discussion to the same conversation as airway and jaw size?
Yeah. The second you mention jaw surgery to a patient, most patients get very scared and may run out the door to the next orthodontist that won't say jaw surgery. Mm-hmm. And that's because in the past, jaw surgery was so intimidating with wiring your jaw shut, long recovery times. What patients need to be educated on is that perhaps jaw surgery is the best way to address their deformity.
Right.
And the orthodontist really has to educate the patient as to what their deformity is and what that means for their long-term health, including the airway, most importantly. So I think there's a lot of stigma around the word surgery when an orthodontist walks into a consult with a new patient. But as long as you preface that and explain why jaw surgery may be indicated, the patient is then best educated to make a decision for themselves. Yeah,
I agree. The patients need to be educated about how we can do jaw surgery now. It's a different thing, but I think orthodontists also, a lot of them, all they know is the 6-8 hour jaw surgery being wired shut, unpredictable results, unstable results. We've been working together at Texas Children's. We collaborated on a lot of cases. That's not the experience anymore.
No. And a lot of orthodontists were trained, the older generation of orthodontists were trained when jaw surgery took 6 to 8 hours, and their patients did lose sensation in their lips and whatnot when custom wasn't available.
Right.
And now with the technologic advancements and expertise, it's a lot more of a seamless process, and patients should understand that's an option for them.
Mm-hmm. Yeah, so I feel like most orthodontists still shying away from recommending surgery, and maybe even afraid to lose their patients if they mention it, or losing the case if they mention it. You think that's true?
I do. I think that's a pretty common theme. Mm-hmm. And because orthodontics is also a business, we want patients to sign up a lot of times for treatment with us.
Right.
And we just naturally will want to say what the patient wants to hear.
It's human nature.
It's human nature. And what the patient wants to hear may not necessarily be what's best for them biologically and longitudinally. One of my goals, I spend a lot more time probably in consults than I should.
It's a great thing.
One of my goals when I walk into the consult room is to help them understand, why their lips are incompetent, what that means for their teeth long term, and what the retention is of those teeth if we do treatment, explaining the options, and then instead of giving an a la carte menu to the patient, really giving my best recommendation for what I feel is best from other patients I've seen.
Let's talk about retention. This is something that never sat well with me when I was in dental school, when I was in residency and learning about orthodontics. And, what we learned was that whenever any patient finishes with braces or ortho, they must remain on a retainer for the rest of their life. And if they wouldn't, then that they're going to have some type of relapse or change in bite. And that never really made sense to me. That just didn't sit well. That you go through braces, you fix your teeth, but then you have to still, in some type of way, remain in braces, which is the way I look at it, for the rest of your life. And what happens is that's not really realistic, because most people are not going to wear their retainers for the rest of their life.
Right.
And they do end up with dental relapse, and they have more crowding, and their teeth their bite opens up, or it goes back where it was. And when they go back to the orthodontist, a lot of times the orthodontist will say, well, did you wear your retainer? And of course the answer is no. And it's almost like that's the fault of the patient. But I don't think that's true. Maybe this might be a more controversial thing, because the leading thought right now in ortho still remains that the ligaments and fibers around the teeth have memory, and no matter where you move them, that memory is going to want to pull them back, and that's the reason. But the more I treat patients in airway, and the philosophy I have is that teeth are crowded, meaning the jaws are too small, and that's why the teeth are crowded. And there's consequences to that for the musculoskeletal system. We have to swallow, we have to breathe, we have to speak. And there's so many powerful muscles in the face that interact with the teeth: the lip muscles, the chin muscle, the tongue, the buccinators, the masseters. So if those things are compensating or inappropriately functioning, they're going to move teeth.
Yep.
And I think that if we miss the fact that the jaws are not appropriate for appropriate function, that's the real reason that teeth are going to move. Because if a plastic aligner can move teeth and braces can move teeth, the tongue is way more powerful.
Soak in the soft tissue.
Right. Yeah. Soak in the soft tissue. So I don't know how much you want to comment on this. That's my thoughts on it.
No, I agree with you. The teeth exist in a position, in a balance between where the tongue is and where the cheeks and the lips are. A great dentist from Florida, Peter Dawson, once said, teeth exist in the neutral zone, which is between the tongue and between the lips. We as orthodontists need to be very mindful of where that is and position the teeth in that most sustainable and stable position. The second we start to pull the teeth back too much, the tongue wins and pushes them back forward. If we flare the teeth out too much, the lips win and the teeth get pushed back and get crowded again. Like you were saying with open bites, if we try to close the open bite down with rubber bands too much, well, the jaw muscles will win and open it back up again, or the tongue if it's a habit. There's no question that the soft tissues and the musculature of the face and the tongue, they win.
Right. I now recommend all my patients work with a myofunctional therapist, and I look at every patient for appropriate airway health and function. And I think that's critical for long-term stability and results. But that interesting thing about being mindful, if it's true then that crowding is diagnosed without recognizing an airway problem or a jaw size problem or functional problem, and those teeth are either removed or straightened, and that space can be even confined more for the tongue and musculature. And then in that sense, maybe even a retainer can be problematic for function, even though they're retaining that straight teeth. Now they're locking in that tongue. And I, from personal experience with patients, if their airway is compromised, it doesn't only affect their restfulness, concentration, fatigue, all these things, but it causes problems with the bite, headaches, neck pain, shoulder pain, and then actually physiological problems. It increases autoimmune conditions. So I think the consequences of not talking about this, and as communities, for both surgeons and orthodontics, because I think that a lot of it's being, for fear of being controversial, it's not really being discussed, but I think that there's a potential to cause problems.
Definitely. Yeah, I think we always want teeth to stay looking straight as orthodontists, but straight isn't necessarily what's functionally best. And so although the retainers might hold those teeth straight, it might be compromising the tongue behind it. The patient has to breathe. Mm-hmm. So the second that retainer is not worn, the tongue wins and the teeth go back to where they were.
Yeah.
Or where they should be based on that person's need, like you were saying, to swallow, to breathe, to talk. Again, just keeping in mind as an orthodontist where that most stable position is for that person is very important before we even start treatment.
Yeah.
When we're treatment planning. I had a professor in residency say that orthodontics is 3 things. It's 50% diagnosis and treatment planning, 25% bracket placement where you put the brace on the tooth, and 25% play as you go, just reacting to things that happen. But that 50% diagnosis and treatment planning is so critical.
I think you have a unique perspective being a craniofacial orthodontist because you're treating patients with cleft lip and palate, craniofacial deformities, really challenging cases. Because of these deformities or discrepancies, they really have obvious functional problems, obvious sleep problems, obvious speech problems. So I think that your involvement with speech pathologists, therapists, those things are unique for an orthodontist and gives you more, a different perspective that a traditional practice may not encounter. And sometimes it's like the disease states and the most pathological things where you get to learn more about normal things.
Definitely. No, it's one of the things I love about working on the cleft palate team is we're just 1/10 of the rest of the puzzle. It's 10% surgeon, 10% orthodontist, 10% speech therapist, nutrition, psychology, nursing. So many different specialties go into the comprehensive care of a child that's born with a craniofacial difference. We all have to communicate so closely to figure out what's best for that kid at that time in their life.
See, the cool thing about that is that, or interesting thing is that it's obvious in these cases, right, that you need all these support members, right? Psychiatrist, a nutritionist, myofunctional therapist, or speech pathologist. But what's not obvious is that all those are beneficial in all patients. And I feel like it's been neglected in the common things, normal patients, because we think that whatever is common is normal. And we're not really recognizing how much people are hurting or suffering or affected by the issues they have. So I think that we're missing traditionally we miss the multidisciplinary approach. Here we have a nutritionist, psychiatrist who work with my functional therapist.
Yes.
So I feel like, but maybe that's because of our relationship with the craniofacial team at Texas Children's and having that appreciation. I don't know.
And we're so fortunate to practice in Houston, Texas, which is, correct me if I'm wrong, the largest medical center in the world. So we have access to all these very niche specialists who have tons of experience. An orthodontist that practices in rural Texas, rural Oklahoma may not have access to that and have to be a little bit more resourceful.
Right.
So it's easy to become a dinosaur when you're just running a business, managing staff. It is important to be a part of a bigger team and know that you have a support system when a patient has another problem.
Yeah.
And we as orthodontists are often the quarterback to seeing these problems develop because we work with young kids all the way to adults. So we interact almost monthly with patients while they're in treatment. We understand if a kid's getting bullied at school. We can refer them to psychologists. We can understand if a patient has an articulation problem, refer them to speech therapy. We can understand if a patient is developing a jaw discrepancy and refer them to a jaw surgeon, orthognathic surgeon. It's incumbent on us as orthodontists to recognize these other problems that aren't just teeth related and be basically a referral source. For their best interest.
Let's talk about pediatric ortho, because I feel that a lot of orthodontists don't treat children until they have adult teeth, which is what, age?
12, 13.
12, 13, right?
Yeah.
But what we know now, or at least I understand, is that that's a lot of missed opportunity to grow jaws bigger, a really critical time period during development before the sutures are closed and the bone is mature. The orthodontist can actually help these kids get out of impacted teeth, crowded positions, airway issues. What is that? A lot of orthodontists don't treat what we call phase 1. You can define what phase 1 is for the audience and where that lies in your thought process and what you've seen in the communities in ortho.
So phase 1 orthodontics is, loose definition would be treatment for a patient that doesn't have all their permanent teeth yet. Most of the time, that's children between the ages of 8 and 10. The point of phase 1 orthodontics, as we learn it, is to make the jaws typically wider or larger to accommodate all of the permanent teeth. Sometimes it's to correct bites if a patient has an underbite to help move the top jaw forward. Why is it sometimes avoided in the orthodontic community? Working with 8-year-olds isn't as fun as working with 13-year-olds. Kids are a little bit more squirrely. They don't love being in a dental chair. It's harder to grab onto the teeth with things like expanders. So it's just, from a chair side perspective, a little bit more difficult and not as lucrative either. You can't bill or charge for it as much. But we feel that phase 1 is critical in many patients to eliminate things like crossbites, make space for all those permanent teeth that are about to come in, adult teeth that need space to come in. Sometimes if you wait and you don't do a phase 1 for a patient, they'll stay with a crossbite in the back that'll cause their lower jaw every time they chew to shift to the side. It's called a functional shift. And then later in life, that shift has actually caused a permanent deviation of the chin that now you can only fix with jaw surgery. Fortunately, we can expand to fix those crossbites and avoid that. The other thing that expansion does in kids is it creates space for all those permanent teeth to hopefully not have to extract 4 premolars, like we were saying before. We believe that phase 1 is very important, although not fun sometimes, can make a big difference in the long term.
Yeah, and how about the airway space?
Airway space
nasal
too.
Breathing, tongue space. The fact that you guys can do that at an early age, I feel like can help kids develop so much healthier.
Totally. Pediatric sleep apnea or airway issues, we're learning more about it. And our protocol for addressing pediatric airway issues is to expand the top jaw first to make more space for the tongue. And then also if they have tonsils that are oversized, recommend tonsils to be out.
Yeah, 'cause breathing is so important.
So important for the normal development of the jaws.
Yeah. So what does that look like? What is phase 1 exactly? How are you accomplishing these bigger jaws?
Yeah, good question. We have expanders that actually are bonded into the teeth. Rapid palatal expanders, the mom will turn the key once a day, and that will slowly distract the top jaw, the suture in the middle of the top jaw, little bit by little bit daily. At the end of the process, the bone fills in the middle, and we now have a wider top jaw. The problem is, as we get older, that suture in the middle, it's like a zipper, and it gets a lot harder to pull that zipper apart and open up that suture. Past the age of 15, it can be very difficult to expand using a regular key-turning expander. And we might have to use something else that's a little bit more invasive to expand.
Maybe like a screw retainer, MARPE. And I think those are getting a lot more sophisticated now.
Yeah, before we didn't have access to MARPE. We can get into this now.
Before we get into that real quick, I want to know, it seems to me like the earlier the better for ability to grow the jaws larger.
Yeah.
What's the earliest that you can start?
So typically we wait for the first molars to come in so we have an anchor to expand off of. The soonest I'd recommend expanding a patient would probably be 6 or 7 years old.
Okay.
That's also when a patient can tolerate being in the chair, able to stay still enough for us to make an accurate expander.
Yeah, that is a factor.
Yeah, for sure. Jaws are just more malleable the younger we are.
Yeah, and how about the lower jaw?
So the lower jaw does not have a suture. We can't expand or distract the chin apart, but we can do lower expanders to slowly move the teeth and grow the arch. So there's a lower expander also that you can use.
And do you turn that as well, or how does that work?
You also turn that, but you just turn it once or twice a week. You would never turn it every day.
Yeah.
Because you'd push the teeth kind of out of bone.
Yeah. It seems like such an amazing opportunity to get these kids treated early and intercept a lot of grief in the future.
Most definitely.
For them. Maybe even avoid seeing me once they turn adults.
Absolutely. Fixing crossbites is big, and expanding the arches for all the adult teeth is also very big. So the expander that we've always used in kids is called a rapid palatal expander, where all we have to do is glue it to the teeth. Mom turns it once a day, and it makes the top jaw bigger because the top jaw is malleable at the age of 12. The second we get past the age of 15, the top jaw isn't as malleable anymore, and we have to go in with something a little bit more heavy duty called a MARPE, mini screw assisted rapid palatal expander. This was developed by an orthodontist out of UCLA named Dr. Juan Moon. It essentially involves placing 2 mini screws on either side of that mid-palatal suture. Once those screws are installed, doing the same sort of turning, but instead of once a day, twice a day, to be able to really expand that suture.
Yeah, and these now you can make them custom, and they can go 2, 4, 6, even 8 screws.
Oh yeah,
to get some real force on them.
He shows cases where he's expanded at the age of 60 using a MARPE. In our practice, I wouldn't go past the age of 30.
Yeah.
And that's even pushing it.
I think what's not talked about a lot is that, especially in the older adults, there's a huge asymmetry in the expansions that can occur. I think over 50% of expanders. My philosophy is that most people that need an expansion also need jaw surgery because the jaws are not just small in one narrow dimension, but they're also behind. So in those cases, at least, we're able to fix any asymmetry once we go to jaw surgery. But I think it gets tricky when people are just looking at expansion with no surgery. You may end up into some trouble.
Definitely. A lot of times transverse problems or width problems are also accompanied by AP problems and vertical problems.
Right.
So our job as orthodontists is to make sure that that transverse is as good as possible for you to then be able to position the jaws anterior, posteriorly, and vertically to maximize airway.
In that respect, what is your philosophy on MARPE or SARPE? SARPE is like a surgically assisted expansion. MARPE is a screw assisted expansion versus what we call a segmental Lafort, so just expanding the upper jaw at the time of jaw surgery. What's your thought process on who will benefit from expanding before surgery or during surgery?
It's a great question. First, I'll talk about MARPE versus SARPE. I believe MARPEs are best for patients between the age of 16 and 25. If you find a patient with a crossbite or an upper jaw narrowness in that age frame, that's the best candidate for a MARPE. Anyone older than 25, a MARPE may not work and actually be a little bit painful. The other patients that are not candidates for MARPEs are patients with very vaulted or high palates, because there's no way to get the expander to adapt to that palatal tissue. Patients older than 25 and patients that have vaulted palates are the hardest ones to do MARPEs in, and you're looking more at a SARPE.
Yeah, I think the other population is the people that have a slant deformity. We call it a cant, but a slant or asymmetry. I feel that a MARPE can exacerbate the asymmetry.
Definitely.
Or that cant. So I think that those are maybe not great candidates.
For sure. And you have to make patients aware of cants immediately at the time of diagnosis. Sometimes you can just try to, like you said, expand transversely, but it's accompanied by other problems that will need jaw surgery later. So with MARPEs and SARPEs, the one downside is that you develop a gap between your two front teeth through the expansion process. And for many young adults in general, you don't want to have a big gaping gap between your two front teeth. And with SARPEs, it's a whole surgery beforehand of needing orthognathics later.
Right. So it's very similar to the upper jaw surgery itself.
Exactly. So my question to you would be, what's the limit? At what point would you consider a segmental 2-piece, 3-piece maxillary advancement or surgery as compared to a SARPE?
Yeah, I would say that for most patients, the upper limit for a predictable, stable expansion during surgery is segmental is around 8 millimeters. I think once it gets above the need for 8 millimeters, then expanding first. I prefer that. But any 8 millimeters or less, I won't hesitate to do it at the time. And I think there's a lot of benefits. Maybe save a year of turning and closing spaces before they can get into surgery by just going into surgery and moving there predictably without any added real risk.
Definitely.
Compared to the expansion itself.
Definitely. So for patients with huge discrepancies like 10 millimeters, maybe are suffering from airway complications due to the top jaw being narrow or speech, tongue space, that's when a SARPE might be useful.
Right. And for most people that are that narrow, they're going to need double jaw surgery. So it's really setting them up for them. But I think that they're rare. I think the indications for SARPE or MARPE before segmental are becoming, they're out there, but I don't think that's the norm.
For sure.
I think most people are going to fall in that area where they need that forward position, counterclockwise rotation, and they can get the expansion they need at the time of surgery. I think it saves the patient a lot of time, effort, and money.
For airway benefit, moving the jaws forward has a lot bigger of an impact than making the jaws wider.
For sure. Well known in the communities that you can expand till the ears come off, but it won't solve the AP problem.
Right.
When it comes to airway. So, and most people are really behind. So I think that the issue was that surgery was traditionally such a difficult operation with a lot of problems. We tried everything we can to avoid surgery. And obviously it's a big operation, but it's so much more predictable, stable, and an easier recovery than it has ever been. So that conversation is now a lot different, and it opens up surgery to a lot more patients.
And when you expand the top jaw during surgery, how do you hold it so it doesn't collapse backwards, inwards?
The custom plates help a lot. Sometimes we have total control with the custom plates because they're printed So sometimes I'll build them stronger. So instead of, for example, 1 millimeter thickness, I'll print them to 1.3. And because that custom plate crosses as one piece, crosses a midline, it's a lot more secure than the traditional plates. And for some modest expansions, it's going to be enough without a splint. I hardly ever use a splint for expansions. What I actually really like is Invisalign for expansions. I prefer that over braces because just Invisalign surgery is so nice. There's nothing on the teeth. There's no metal, there's no hooks, there's no buttons. A better experience for the surgeon, but it's also a much better experience for the patient and more cleanly. They're easier for cleanliness and hygiene, but a lot more comfortable. But the benefit of expanding with Invisalign is that we can use an expanded Invisalign type aligner and pre-print that based on the plan. So we plan for that expansion. We can print an aligner for that expansion and use it just like a retainer for someone. That's what I've been doing for them.
And that's your splint to hold the jaw expansion until the bone heals.
Exactly.
That's so cool.
And the patient uses it just like they would their Invisalign aligner.
And that's all built off of the surgical plan on the computer.
Yeah.
It's so cool. And I was going to ask you too, what is, in your mind, the advantages in healing times between Invisalign and braces after jaw surgery?
Yeah, I think that the hygiene is such a huge advantage with Invisalign because especially for, traditional surgical wires and hooks for setups for, the way we set up braces traditionally for surgery, there's so much metal. Because they have the strongest rectangular wire. They have hooks, brackets on every teeth and hooks in between those brackets. And those feel like they tear up the gums. They're really uncomfortable. And so much surface area for biofilm and bacteria. And it's uncomfortable for the patients to even want to brush their teeth or floss. It's painful. I've seen an easier recovery with Invisalign.
Yeah, and I can tell you that personally because my dad got jaw surgery with Dr. Alfi back in April. And we set him up with Invisalign instead of braces. And my dad's a dentist. He was back treating patients 6 days after surgery. I think the surgery was only 26 minutes long. So you were in and out of there. And also because he was able to clean his teeth so well after surgery that hygienically it was a lot more advantageous than braces.
Yeah. I mean, it's awesome to hear that a dentist can go back to work 6 days after jaw surgery. And we've had other dentists do a similar timeline. And 26 minutes for a jaw surgery it's a different operation.
Totally different. There's less retraction involved, less exposure of the tissues, which leads to less swelling, right? I can tell you my dad that afternoon, we were walking around Rice Village drinking water. He was swollen a few days later, but 6 days later, he was back treating patients in his clinic in Maine. And so if you told me 5 years ago that you could get your lower jaw moved forward 7 millimeters with orthodontic surgery and be back working your normal life within a week,
you wouldn't believe it.
I wouldn't believe it.